Yeah. And I think that's something I want to really bring out today. And I want to kind of move on to a little bit, which is really that multifaceted nature of NF1. And it's really what prompted Childhood Tumour Trust to drive this important conversation. And, today's title, That One Degree of Separation, really illustrates the need for HCPs and for everyone to be really open to sort of thinking NF1. So I want to talk a little bit more about the importance of that multidisciplinary care, because it's certainly coming through that there are lots of different moving parts here, and there needs to be that real drive to bring things together. It's certainly a condition that's more than skin deep and lots of different factors happening. So, Mary, if I can come to you, what are the key benefits of that multidisciplinary approach, particularly in NF1? And can you give me any examples of maybe how different specialties might contribute to the care and collaborate together?
Yeah, absolutely. So, as I said before, I sit within a complex service that is multidisciplinary. I think we've got at least 10 different specialties as part of our team, which I'm really thankful for. So, firstly, my service is neurology led. So anyone comes and we'll see a neurologist, and that's to check that, we know with NF, it can cause lumps to grow on nerves. And so, the majority of them will sit there, not cause any nerve problems at all. But what we're looking for is, are they affecting the messages that go from your brain to the rest of your body, affecting how those nerves function? So that can be done again with a pediatrician when they are, assessing your kids, making them do all fun things like hopping and, you know, pulling and pulling and all those sorts of things. Just explain to people, I'm like, oh, that's just telling us that the nerves are working really well. And that's what we want to check. And then we also would be checking that, their spine is straight. So we're going to get them to, bend over and check. And if anything that comes up that you're like, that's a bit not normal, then you might go see an orthopedic person. So they're specialist bone doctors. You might go see, like I said, neurologist. Ophthalmology, we want to be having a look at. And then with learning, so being able to, be supported at school, so have your SEN involved, but also, maybe an educational psychologist, which again can be very variable depending what region you're in. And also like physio as well could be really helpful, which we have within our own team. And as I work with adults, we spend a lot of time chatting to people about visible difference and, referring to plastics. So we work really closely with our plastic surgeons to, help manage maybe pain or visible difference, as well as working with a lot of other specialist
And what does
surgeons.
that look like so you mentioned that you've got over 2,000 patients and obviously you don't have capacity to see everyone. So for those that are not kind of coming under your complex
Yeah.
service, what does that multidisciplinary and care coordination approach look like for them? Are they seeing different specialists in different settings? Is there that level of coordination, or what does that typically look like?
Yeah, so I think for a lot of different regions, that can be very variable, which I know is something that I think Dr. Evans is really passionate about, is, trying to get more continuity,
Yeah.
regardless of where you're living. So yeah, for children, you're being coordinated by a pediatrician. For adults, it's our GPs, which also can be a bit contentious,
A bit
depending
variable, would
again
it be fair to
your
say?
region. Yeah, we'll say it's variable, as your GPs. But again, so thankful for the charities in the UK who help with advocacy of making sure that people are getting the information that they need. That we are equipping our local teams to ensure, for women over 40 that they are going for their yearly mammograms. That is something that's quite new and again can be very variable depending what region people are in. That we're supporting that information getting out. And so we're very
Amazing.
thankful for the charities and the work that they're doing there.
Absolutely. Yeah, they've done so much. And I think, it's exciting to see what more they're going to be doing in terms of awareness. And Sal, coming to you, I mean, obviously you said you had to wait 7 months for that kind of confirmed diagnosis, but since that point, what has care coordination looked like for you and your children? Are you getting sort of do you feel that everyone's working together and coordinating all these, audiology and the different specialties that you need to be seeing for William as well
Um,
and for yourself?
Yeah, I mean, we're fairly obviously early on in the journey, but our view so far really is that, you know, all the different specialities works kind of separately. So we see the NF1 team, and they are brilliant, but the 3 appointments we've had have all seen a different doctor. So you kind of feel like when you go, you have to re-explain everything again, which is fine, but it would be nice to see
Yeah.
the same doctor when we go. And then obviously ophthalmology see us separately as well at a different hospital. I actually had to ask to get the children referred to ophthalmology myself. And then often the NF1 doctors might say, oh, have they had their eyes checked recently? So it's kind of up to the parent to kind of coordinate all the different services together. It's the same when you go to paediatrics, you then have to update them about what's happened. I just feel like if they had some kind of central system where, you know, all the information was, or where they were all working together, it would be better. It would help a little bit more.
Sorry, on you go, Sal. I didn't mean to.
I was just saying, in terms of myself, because I'm classed as non-complex, I don't actually get seen by any specialist in NF1. So I asked to be referred to a dermatology just because I know now, because they've been biopsied, that they are neurofibromas on my skin. So I do see dermatology, but I was already under ophthalmology at the time. So when I went to my appointment last year, I then had to inform them that I had NF1 and could they look for lesion nodules. And obviously that I've got loads, they were very clear. And they were there with the cameras because they were interested in it, because they hadn't seen anybody before with NF1. So they wanted to take pictures for the junior doctors. And so that's been our experience. So if I'm not necessarily negative, just frustrating that.
Yeah. And the impetus is very much on you to be the driving force in identifying who you need to see, coordinating that, conveying the messaging between the different specialties.
Yeah, I mean, it's always been a little bit like that one. I remember being sat in an appointment with William when he was quite young and saying to them, I really feel like all these things that you're telling me are not right with William are connected.
Yeah.
Do you know what I mean? So I knew, you know, seeing the physio, speech and language, someone for his behaviour, for his ADHD and his ASD, audiology, he has migraines, we're seeing paediatrics. And I remember asking that question, that I felt that there was something underlying going on.
Yeah.
And I do wonder sometimes if their team had got together, and I know it's difficult because they see so many children, maybe the dots would have been connected a little bit earlier. But
well, it's really clear that that care coordination is a key priority. So, Will, coming to you, what do you sort of feel the future trajectory in terms of improving MDT care for NF1 is looking to be? You know, is there a movement to improve that, or what do you think the future should look like for that?
Yes. I mean, I think obviously, as has already been touched on, NF1 as rare diseases go is a common rare disease. You know, so it is getting close to the threshold of the definition of a rare disease. So the complex service provides a very, as we've already heard, you know, in the two centres, provide a very unique service, but that is the tip of a neurofibromatosis iceberg. You know, for the actual patients who end up in the complex service. So for the other patients, then that's it. As has already been touched on, there's quite a lot of variability in care. So depending where you work, it may well be that there is a paediatrician, if you live in a city, working in a single city, who isn't part of a complex service, but actually sees a lot of patients with NF1. And for those children, and they're probably very well linked into local clinical genetic services with additional expertise, quite possibly very well linked into the regional complex service. And then they're very aware of all the problems that they can have, and already have those links very neatly into the other specialties within that hospital, and with just by the quantity of patients that they see. But as I say, that shouldn't almost be left to kind of geographical chance and things like that. So really, I think the key bit about this is ensuring the right patients are looked after in the right place at the right time. So one of the important things is also making sure that patients who are not under the complex service access the complex service when they need to access the complex service, when they develop the complications and problems that are not being managed, and making sure those flows of information and getting adequate information is appropriate. There's some really good resources, and I think the key bit about resources is they should be targeted for the patient that you have in front of you, but also the setting in which you're seeing the patient. So it's already been touched on. If you're a child with neurofibromatosis and you're not under the complex service, you should be under the care of a paediatrician. And the paediatrician should be doing the general review and then involving other specialists. Because I think it is also important to note that for a large number of patients with neurofibromatosis, they definitely do not want to be traveling to a complex service in a faraway city. There is no need. It's a waste of everybody's time. And also they're getting on with their life. They don't need to have this, but they do need to be able to see someone who doesn't have to be an expert, but needs to know what are the important things for that patient in front of them, and then where to go when problems arise. So I'm a GP, but I work in clinical genetics as well. So one of the projects that we did in our region was actually to map what is recognized as good care for children and adults, but refine the resources. And there's some amazing resources which are available online, both with the Childhood Tumour Charity, but also with Nerve Tumours UK. So really useful, really good resources that we use, but then actually targeting those for primary care use. So really unpicking what we would normally do, because there is no point telling a GP how to suck eggs, how to manage hypertension. We know how to manage hypertension, but there are some really key bits. So any adult with raised blood pressure, for example, any adult who gets diagnosed with raised blood pressure who has neurofibromatosis type 1 needs to be investigated for secondary causes. And that is uniquely different to almost any other patient. And most GPs will definitely not know that. And unless the patient knows it, is highly unlikely that they will be investigated. They would just be managed in the normal way. And we've already touched on breast cancer screening. All people with neurofibromatosis are considered at moderate risk of breast cancer, and therefore they should qualify for whatever at that stage, which currently is annual mammography over the age of 40, but whatever would be considered moderate breast cancer. So that information needs to be given to primary care in a really succinct way, which is actually what is different to normal care and what is important to know about. So what are the things which is different to what you would normally do, and what are the really time critical things and the things where you need to be flagging this immediately? And then what is the route for that? Is it a normal referral route, or do you do something uniquely different because the patient has neurofibromatosis type 1?
Yeah, absolutely. So it's a complex sort of piece of puzzles, and it's so nuanced to the different individual, isn't it, as to what their needs are. And before we move on topic, I want to come back to you, Catherine, and just think about the sort of psychological impacts a little bit, in particular thinking about the MDT. And you talked about how you and your husband sort of had a different appetite for how much information you wanted in those early stages. But do you feel that having access to that MDT, of knowing that you could access everyone you want, does that impact your ability to cope and therefore your kind of psychological well-being? Does it help with Alfred's sort of coping with things because he knows he's got a team of people around him? What's your thoughts on that?
Definitely. I think because we have been very lucky in the care that he has received, and the majority of it, not all of it, has been in our local children's hospital. So, there is an element of familiarity. We know that hospital like the back of our hand now. And we know most of the doctors and nurses that we see. We've seen the same people now for the best part of 9 years, which is quite different to the situation that Sal was describing earlier. And I think, we very much are seeing the benefits of that. So we are familiar with the people, we feel comfortable, we're happy to raise concerns. We do have a very good relationship, particularly with oncology and ophthalmology. Mm-hmm. So if we do have any simple concerns, because anyone with NF1 in their family will know that the really minor things that probably every parent has a concern about, whether it's a sickness bug or whatever. You just look at it slightly differently through the NF lens, and you think, oh, could it be this or could it be that? Or and so we are very lucky to be able to have the kind of relationship where we can ring or email and say, oh, I'm a bit concerned about this, what do you think? And they are very responsive. So I think in that sense, that comes with a huge element of reassurance on our part, that knowledge that we feel that we are being well looked after. Definitely makes us feel more at ease with the situation that we are in. And we sometimes joke it's almost like Stockholm syndrome, really, where if we see our appointments stretch out slightly longer. So at the moment, our oncology appointments are every 8 weeks. They were weekly at one point. It feels like a really long time.
Yeah.
Alfred will get to a point where he's saying that he's missing his oncologist because he hasn't seen her. That is the kind of situation that we're in, and so obviously, we take that as a positive.
There's a lot of comfort that's coming from that, isn't there?
Yeah,
which is important.
Definitely.
And I wonder, Will, whether and you mentioned that you've done some work locally looking at mapping kind of the adult and the child experience just generally in terms of good care. Do you feel that there's a role for almost, particularly for those that don't sit within, don't have the benefit of someone like Mary coordinating their care? Is there a role for maybe sort of like a navigator or someone that kind of supports the pediatrician in bringing this all together, in recognition that it's very difficult for a pediatrician to have that level of involvement over all of their patients? Do you think that that the future of patient-centered care might involve that type of role?
Definitely. I would say that coordination is key. So particularly, as an outsider looking in that doesn't have a great deal of knowledge, looking at what Sal has described earlier on, feels to me like where we were very, very early in our journey, where some of Alfred's care was at the local hospital, and most of it was at the children's hospital. And our situation changed when all of his care was transferred to the children's hospital, so it was all under one roof. And that's when our experience changed quite a lot. And I feel that is probably because ultimately they're all on the same software package, and it's easier to share that information between departments under one roof as opposed to cross borders, cross trusts, etc.
Is that something that came up, Will, to you? Is that, when you looked at it, does that notion of having a kind of a navigator role ever come forward as a possible future model from a GP perspective?
Yeah, I mean, absolutely. I think there's almost two. I think there's two approaches there. This can be a person, but also almost a little bit, as Catherine's touched on there, is ensuring that the information technology systems support us in what we're doing. So that, removing the duplication of effort, making sure there's communication between different people. But the work I did in neurofibromatosis was part of a larger piece of work looking at rare genetic conditions and trying to improve care coordination, but actually trying to piggyback that in primary care, but trying to piggyback that onto stuff that is already being done. So we already use quite a lot of templates in primary care, and we already do, for example, annual learning disability reviews. I know we're going a little bit off topic, but this is work that's already being done. So optimizing that, so when you are doing work that you're already doing, you're doing it more targeted for the individual in front of you for whatever is the cause of their problem. But I mean, I guess again, always the challenge is with neurofibromatosis is because actual fact it's not so rare. You can start to plan things potentially not at an individual GP practice level, but certainly on a kind of a relatively small geographical area. You have the number of patients to develop a degree of expertise, even in a primary care setting. Obviously, that's not the case for other rare diseases, but then you start to think, well, actually, are there commonalities? And often it is, some of what about neurofibromatosis is it's not particularly complicated. You just need to be given the right resource in the format and targeted for what are the questions that the patient is going to come to ask you about and what the problems they're going to present to you about, and know where to signpost.